Personally, I feel it is all guesswork. We are just doing upsize, downsize. We don't know anything. ये सही है ऐसे ही बोलता है हो भी जाता है तो but in the next talk when Nick Clement is speaking he's doing a good study so the long term goal long term functional outcome of robotic versus navigation versus manual is the same so that is another point long term means maximum 5 years has come up till now. Another thing is that when you talk of robotic surgeries, initial recovery period is faster. That is also proven. But that is the way to go actually because once you start using the robots or anything, like we did a unicompartment knee, it becomes very easy. You don't have to think and think. It's like well, we are 20 minutes away from the TKR, live TKR surgery, and just actually 20 minutes, Adarsh and his talk was there. So TKR would be on in 20 minutes. So you'll see the TKR which would be done would also be very, very fast and furious and very good. So we don't retract anything, we don't cut anything. I mean, this is what I feel. I mean, we were there, we were doing navigation. So some people never used to like, Sarangi never used to like navigation. Picard used to do all his navigation, David all navigation. Yeah, so Dr. Nick is ready. Yes. Hello, Mr. Nick.
I'm extremely sorry I'm a little late. I thought it was at 9:30 and I couldn't find the link.
It gives me immense pleasure to have you here. And we are sitting with the expert group of robotics person. And I would like you to kindly present your experience vast experience on robotics and your recent papers which you have sent it to me.
Brilliant.
So Nick, I follow you
on,
and he's got more than 530, 50 publications. And he used to teach me that this is the sofa, this is the bed, while I was doing my registrarship at Edinburgh. And now he has 550 publications. He's a Google scholar and publications anywhere. Let it be Corona, let it be orthopedics, hand. He's a big man. Pay regards to everybody. Sir at Edinburgh.
Ashish, you're too kind to me. You're too kind. Would the host be able to allow me to present when I share the screen? The host needs to disable the sharing, if that's all right. Brilliant. Thank you.
Make host. देखो बेटा ITF संभालो क्या करना है? Technology fail हो गया हमारा. Yes, you can.
Now, yeah.
You are the host now. Yeah.
Brilliant. Ashish, can you see the screen okay? Right, so it's been a great pleasure to present it today. I'm sorry I can't be there in person. I wasn't allowed any more study leave to come and travel because I've had a little bit too much study leave this year, but gives us, Ashish, thanks ever so much for letting me present this work. I started this work around about 6 years ago now when I was down in Newcastle on my fellowship, looking at robotic assisted surgery. So this was in England. I'm now up in Edinburgh. So robotic arm assisted versus manual Rome study, total knee replacement, randomized controlled trial. But I thought I'd have my declaration slide. I've got a funny accent. I'm extremely sorry. I hope you can understand me. I'm from Sunderland, which is in this part of England. It's kind of in this grey box here. That's kind of, it's not, people in England don't really know where it is, and people in Scotland don't like us because we're from England. So it's kind of a grey area. It's kind of what's called no man's land. And we're kind of in the middle of the two. I now work at this hospital on the left-hand side, the Royal Infirmary of Edinburgh. It's got a little bit larger now. It's got an extension on the front. It's got over 1,000 beds within the main hospital. But I live in the Borders, which is slightly south of Edinburgh, and I have these views. That's Scott's View on the right-hand side. In fact, Ashish knows this area very well because he was down in Melrose with me at the Borders General, so he's seen these views as well. And this is one of the landmarks next to where we live. This is the Leaderfoot Bridge, and we had Indiana Jones visit us last year to film some of his new blockbuster film, The Dial of Destiny. So that's our claim to fame in the Borders. So I thought the plan would be just go through robots, where we've come from, where we're going to. I know we've probably covered some of this already, but kind of my journey in amongst that, how the Rome RCT was set up, some of the outcome comes from it, and some of the key messages. It's coming out, it is accepted for the BJJ, and it is in next month's BJJ in September. So we're all very much aware robotics has been around for a number of years. This is the Acrobot, 1998. Took around 3 hours. It was a fully automated robotic unit. Took probably too long, but things have advanced. You've got the Navio, the Rosa, and the market leader, which is obviously the Mako, bought by Striker for 1.7 billion back in 2013, and probably a shrewd investment because it's the market leader and probably making them a lot of money. So this was a systematic review we did a few years ago. It was published last year, but we did it a couple of years ago with one of the fellows, robotic arm assisted total knee replacement, systematic review, meta-analysis, and that showed that you're more accurate, which is, it's no surprise, is it? You use a robot, you're going to be more accurate. Posterior coronal offset and varus valgus alignment. But then when you looked at complications, no difference. But that's probably because the absolute numbers were quite low. There was only 620 in one arm, 562 in the other arm. When you look at complications, you need thousands. So we're not quite seeing a difference just yet in the literature or in the registries. But what we did see, there was a significantly better functional outcome. That's the WOMAC score at the top, and the physical function was 3.7 points better. And I'll come on to why that's kind of relatively important. It's less than the minimal clinically important difference, but nonetheless it is a significantly better outcome for the robotic arm. So my journey started with Prof. Dehan back in 2017 on my fellowship there, and we set up this randomised controlled trial. It's been a real pain because we had COVID, and COVID really scuppered us, and we had a few lost to follow up. I'll come on and speak about that in a bit. Our primary aim was to assess whether robotic total knee replacement had a better early outcome compared with manual, earlier being 6 months. And then there's a whole host of secondary outcomes, expectation, health-related quality of life, and patient satisfaction. So randomised controlled trial, 1-to-1, we had relatively strict inclusion criteria. This was just for varus knees. That was partially correctable in less than 20 degrees of varus. 1-to-1 randomisation, outcome measures being the WOMAC. It's a slight error in the spelling there. Forgotten joint score, hospital special surgery expectation score, EQ5D for health-related quality of life, and a satisfaction score. This is our consort flow diagram. We originally powered the study for 40 in each arm, and due to COVID, we increased that to 50 in each arm because we lost a few during COVID at the 6-month follow-up mark. So, results. Primary aim. There was a greater improvement in the robotic arm with a difference of 3.8, but this was not significant. And this 3.8 is nearly identical to what we found in the systematic review that I just presented earlier. So we were underpowered to show that difference from a statistical point of view, and also it's less than the minimal clinically important difference, which is around about 9 to 10 in the WOMAC score. Looking at all the other results, just as Ashish was saying there when I logged on, and I apologise again for being late, that the early functional outcome seems to be better, and certainly with pain was significantly better at 2 months in the robotic arm, and it was approaching significance at 9.5 points difference. But you can see there's no other differences in any other of the functional outcomes there at 2 or 6 months. Now we looked at the MIC, minimal important change. So where a patient's gone from and went to. So when you looked at the absolute numbers, those undergoing robotic surgery had a higher chance of having a minimal clinically important improvement in their pain score, both at 2 and 6 months. Remember, this is a secondary outcome. We're not really powered for this, but this may well be a type 1 error. We found a statistical result when maybe there isn't one, but there's certainly a trend in the data that's towards better pain relief in that robotic group. No difference in expectations met, satisfaction. Although there was no significant difference, there was only one patient dissatisfied with their knee at 6 months in the robotic group as opposed to 5 in the manual group. But we're going to go on and follow the patients up to 12 months and we'll see whether this changes. So in conclusion, there were no statistical significant or clinically meaningful differences in the WOMAC functional score being the primary outcome at 6 months, but the robotic arm group did have a higher likelihood of achieving a minimal clinically important difference both in pain at 2 and 6 months. There were no difference in satisfaction, health rate, quality of life, or expectation fulfillment. But if I go back through those tables again, you'll see there's definitely a trend in the data that there's a better outcome in the robotic arm. Then that led us to think, well, if you don't offer robotic surgeries to everybody, who should you offer it to? Or are there any specific groups that benefit from robotic surgery? So we split the group into two, males versus females. Males do better than females after robotic surgery, both significantly, clinically significant and statistically significant, the better outcome. We then looked at age. Younger patients, we just split the group into half. The mean was 67 years of age. We split them in half and we compared those younger with older. Those younger patients, 67 or less, had a significantly better outcome, which was both clinically significant and statistically significant. We looked at preoperative function, the WOMAC, that didn't really make a difference other than the pain score. So those with the worst pain preoperatively had a better outcome if they had a robotic knee. Look at EQ5D, not really much of a difference. So, in conclusion, robotic surgery is certainly associated with a clinically significant better outcome in early functional outcome in younger patients, those who were male, and maybe those with a worse preoperative knee-specific score, the WOMAC. Maybe we shouldn't be offering robotic surgery to everybody, but maybe these groups that may benefit from robotic surgery should be investigated further in future studies to allow optimal use of healthcare resources. Further work, we're looking at gait analysis at the moment, and we're seeing some trends in better gait and tank it up and go tests at 1 year in the robotic group. We're doing a cost economic analysis, and we're also looking at the outcomes. This is just 6-month outcomes I presented today, but we're going to look at the outcomes at 1 year as well. I suppose the real question is, what would you want if it was you undergoing surgery or a member of your family? What would you want them to have? I'm a technophobe. I don't really like any type of technology ever. It's probably coming, isn't it? And I think we should embrace it. It's like the iPhone. We've all got some kind of massively complex phone now. I think we'll probably have to embrace it with artificial intelligence. I'm sure in the future a patient will come in, you've got this pattern of arthritis, this preoperative score, you're this age, you're this sex, you're this activity level, this is where your knee needs to go in whatever alignment, kinematic, mechanically aligned, whatever it might well be, and then that robot puts it in that alignment every time and gets the best outcome for us. That'll be the ultimate outcome. But whether this is cost effective and whether it's affordable, I'm not quite sure. Thanks for listening. Any questions?
Hello, Dr. Nick, this is Dr. Shishidhar.
Hi there.
Hi. My question is, you said the pain scores are better in robotic compared to manual.
Yes, certainly the absolute score. The problem is we've used an NDID in the WOMAC score of 10 to power the study. And when you really think about it, 10 points in a WOMAC score is a lot. It's 10%. Like, to make a knee replacement improve by 10% or 10 points, an outcome, that's a big intervention when you've already got a huge benefit from the knee replacement independently. To expect another 10 points just because it's a robotic knee, I think it's expecting a lot.
Yeah, my question is, did the patient who underwent robotic surgery know they underwent robotic surgery, or how was it?
So, Great question. So we tried to, everybody needed a preoperative CT scan. So, or those undergoing robotic surgery. And then we went to ethics to ask whether we could scan all patients, and they said no. So, if a patient was aware of the whole process, we didn't tell them that they would need a CT scan, and we just CT scanned those that were on the robotic arm. Potentially, they may know because they didn't have a CT scan, but only if they knew they needed a CT scan to have the robotic surgery. We've actually since done a study looking at the patients and asked them, what do you think you had at 1 year? That's when we're going to unblind them at 1 year. And when we asked them, half of them got it right and half of them got it wrong. So even though they weren't blinded fully, because you could probably figure it out if you read about Mako and know that you needed a CT scan, patients didn't know.
So patients technically didn't know that they underwent a robotic surgery.
No, we didn't tell them. But if they knew about needing a CT scan, they could just read about the Mako. They know they need a CT scan beforehand, then they would know that they've had a robotic knee replacement. So we weren't allowed to fully blind it. There's a racist study that's going on at the moment in the UK, which is blinded, and everybody gets a CT scan now.
The question why I asked was because I had a patient who had X implant on the right side, and
Yes.
he was told that Y implant is better and you will be happy. So he came for me asking for the Y implant, and I did Y implant for the left side. Right was fantastic, not done by me, by a different surgeon, but right is doing fantastically well. Left I used Y implant, and he is very happy. So I feel patients thinking also makes, I mean, if you know that you are a robotic and it is better, maybe they say, I have got lesser pain or something like that.
I think that's definitely true. It's like all things in the placebo effect of having a professor operate on you, or the consultant rather than the registrar, or having the latest knee or the latest hip, even though it might not have very little evidence behind it. It might not even have 10-year survivorship evidence, but just because it's the latest thing and it's been advertised, I think you're right. But on that placebo effect, if patients knew that, or if that placebo effect was helping, you'd think that the functional outcomes will be better as well, not just the pain outcomes. You'd think all the functional outcomes will be better as well. So I don't know, but yes, there's definitely bias in there, and there's definitely bias, and it is what it is at the end of the day.
Thank you.
So, Dr. Nick, this is Dr. Mrinal Sharma here. I have a question for you. Do you think the make of the robot, as well as the surgeon who's performing it, makes a difference in the functional outcomes?
So I think that's a great question. We've just looked at some Navio total knee robotics from Swelliok in London, and there's no difference between the two. But they were mechanically aligned robotic surgeries, as opposed to this, where they were restricted kinematically aligned surgery. I think it's a great. I'd like, at the minute, we can't really do within the NHS Mako for everybody because we don't have CT scan capacity. We'd have to get 800 CT scans at my hospital every year, and we don't have that capacity. So certainly the Velis is the new DePuy robot. That's an imageless system, but obviously it takes a little while to do all your landmarks intraoperatively, and I don't know how. Certainly with the Mako, it adds about 10 minutes to the operation, but that's already when you have your landmarks more or less set out, as opposed to imageless, where you really have to map the knee intraoperatively, and I have no experience of that, and I suspect that'll take a lot longer intraoperatively as well.
No, I think it's the other way around. I've worked on the Valis, and it takes a little lesser time for the intraoperative landmarks. But I think there's no study right now to predict which robot is going to do better in terms of the functional outcome. I think you can, if you have access to 2-3 robots, you can do that in your center. The other thing is, where do we stand today in terms of AI, in terms of robots having, a brain of their own and guiding the surgeon in terms of that this phenotype or this kind of anatomy, Asian patients, this is the kind of slope you should put, this is the kind of releases you should do, this is the kind of deformity correction you will achieve, and you will get a better outcome. Where do we stand today in terms of that? In terms of this the robot actually using his brain and guiding the surgeon intraoperatively?
I think that's kind of, well, that's the ultimate, isn't it? But I think we're a long way from that just yet. At the minute, we've now got a robot that can put the implant in anywhere we like, but we don't know where we want it now. So we can put it in precisely, but we don't know where we want it. And I think that's where the next decade of AI will come. Or do we mechanically align valgus knees? Because we know that or do we actually have a tolerance to what we do with a valgus knee? Varus knees, do we keep them constitutionally varus? Or do we, it's really hard, isn't it? It's like, in releases, and I know with the study that we did, there's very few soft tissue releases other than the approach and taking away the osteophyte. There was no other soft tissue releases performed in our cohort. So I think that will be the ultimate, but at the minute I think we're just at the very beginning of kind of trying to gather data and figure out what what outcomes we're going to aim for satisfaction, if it's a functional score. Yeah, I think we're on the very urge. But it's good to know about the VELUS, because I used the VELUS in a cadaver lab, and I found it but I took a long time because it was, obviously I was just learning. So it's interesting to think that that's faster, because that's obviously doesn't need a CT scan. That's good. And when you've used the VELUS with me and the Mako, you've already got an operative plan, but the VELUS, I assume you're going to make your operative plan intraoperatively. Does that slow you down at all, or does that that would stress me out a little? I think I've had a plan halfway through the case where I wanted it.
I don't think it slows you down, because you're doing the gap balancing primarily. So take the tibial cut, you've according to your measurements intraoperatively, you have a tensioner there. So that gives you the gaps, and that helps you in balancing intraoperatively. You just need to do the mapping of the bony landmarks, and that's pretty fast. I've seen surgeons doing it in 20 minutes, robotic surgery. So on a live patient. So I think someone who is using a brain lab or who has been using navigation for 10 years, it's like a cakewalk for them.
Yes. Yes.
Yeah, going back to the question of what Dr. Mrinal asked, I think we are in the phase of collecting data. I think every company is very conscious of doing this. Like for example, in Stryker, they've started a new division called Digital Robotics and Enabling Technology, where every Stryker device in the hospital is updated to be smart, so that it can be hooked onto a cloud, and every data point is directly being captured. Once they have so much of data and information, then they have to sift through it, use all the algorithms possible, and try coming up with solutions. For example, Tesla had to wait for million data points before they actually went through and did the autopilot feature. So definitely companies are cognizant of that this needs to happen. But right now we are in the phase of acquiring all that data. And then that's the reason it is important that more surgeons go through this, collect all the data, and then feed it to the respective companies so that there can be further work done on that.
I understand your point, Suhas, and to Dr. Nick also. I think US, they were collecting data for almost now 8 to 10 years now, but they have not produced anything productive till now. UK, they started in 2015, 16, and probably now you've got robots all around in UK, and we are just getting robots now in our part of the country. So we'll take another 10 years maybe. Yeah. Our data will be next 10 years. Your might be ready earlier. So I was just trying to ask if you have already started collecting those data, and some inputs have been there from the companies whom you're using the robots.
So that goes back to his point as to we still are finding what's the target is, right? You have precision, but we need to know whether we are accurate or not. We need to go,
Yeah, so the target. Another question, Dr. Nick, sorry, I'm bothering you. In a varus knees, we usually put it in the kinematic alignment. But what about the valgus knees? Would you put it at 3 degrees of valgus, 2 degrees, 0 degrees? Where do you align for in a robotic surgery in a valgus knee?
So, at the moment, we don't have a robot in our hospital. This was just done in Newcastle when I was there. In my hospital, I just put them back to neutral. I very rarely leave a valgus knee in valgus. But if you look at some of the kinematic work that's been done, we should be. It's just because that's traditionally how I've been trained, is to some varus knees, you leave in a little varus, you push them back towards neutral, but you're going to tolerate a bit of varus. A valgus knee you put in neutral because you don't want to stretch out that MCL. But that might well be the wrong teaching. There's certainly a lot of evidence now with kinematic alignment is to put a patient back to valgus. I'd be a little using manual techniques. I'd be a little cautious of doing that. But maybe with a robot, that could be the next study, or certainly from. I suppose the alignment of a valgus knee is not really about the functional outcome. It's about trying to stop the MCLs from stretching out and that knee failing. Isn't it? That's what it's about. But certainly the survivorship studies would suggest that's not the case if you kinematically align a knee. So I think that's a question that is going to have to be answered in the future. I can't tell.
Yeah, thank you.
Now I invite Dr. Adarsh Anaparide for his topic. Let's discuss the future technologies, robotics in TCAR and your experiences with the Mako.
Nick, you can be here and you can ask questions, anything. Yes, thank you for joining us. Regards to everybody at Edinburgh.